Okay, let's unpack this. You've sent us a stack of sources, all pointing towards one specific and often frustrating topic, sports hernias.
Mm-hmm. Also known by the slightly more technical name, athletic pubalgia.
Exactly. And this deep dive is specifically for you, pulling the most important insights from the material you shared, helping you, cut through the noise.
Our mission today is really to understand what this thing is, why it's such a headache for athletes, and what your sources tell us about diagnosing and treating it.
And straight away, one of the, most surprising things from your material is actually about the name itself.
Absolutely. The term sports hernia, it's kind of a misnomer, ironically.
A misnomer? How so?
Yeah, that's one of the key takeaways right up front in your sources.
Okay.
It often isn't a hernia in the way most people, understand it.
That's fascinating. So, okay, let's start there. What is a sports hernia or athletic pubalgia if it's not usually a classic hernia?
Well, fundamentally, the sources describe it as a complex cause of chronic groin pain. It's especially common in athletes.
Right.
And the condition itself, it was first formally described back in 1980 by a British surgeon, Dr. Jerry Gilmore.
So it's been around, medically speaking, for a while. But you said the name's misleading. Why isn't sports hernia quite accurate?
Because in most cases, and the sources really stress this, there isn't a true fascial defect.
Okay, what's a fascial defect mean in simple terms?
That's the hole or the tear in the abdominal wall muscle layer that allows tissue to sort of bulge through. That's what defines a traditional hernia.
Okay.
But with athletic pubalgia, that bulge, that's usually not what's going on.
So the name makes you picture a bulge, but the real problem is often something else entirely.
Precisely. And this lack of a classic bulge, plus the fact that there isn't even one single universally accepted definition. Well, that really adds to why it's so tough to diagnose.
Yeah, I can see that. It sounds pretty elusive. Who tends to get this? Is there a typical profile?
Your sources point to a very strong demographic pattern. It mainly affects males. We're talking well over 90% of reported cases.
Wow, over 90% male. Okay, so predominantly male athletes with this chronic groin pain, but it's usually not a typical hernia. If it's not a hole, then what is the main theory from your sources about why this happens? What's actually going wrong?
The leading idea, the hypothesis presented in the material, points towards overuse injuries, but specifically ones that come from underlying muscle imbalances in that whole core and pelvic region.
Muscle imbalance. Tell me more about that. What's out of balance?
Okay, think about the muscles around your pelvis and groin. You've got your abdominal muscles attaching higher up, right? And then your adductor muscles, those inner thigh muscles, attaching lower down near the pubic bone. The theory is often about a strength difference.
Like one set is stronger than the other.
Exactly. Often weaker abdominal muscles compared to much stronger hip adductors.
So it's like a constant uneven tug of war happening right there at the pelvis.
That's a great way to put it. And that constant uneven pull puts way too much stress on the structures that make up the lower part of the abdominal wall near the groin, the inguinal wall.
And does what they find during surgery support this idea that those specific structures are under stress?
It does, yeah. When surgeons operate, the sources say that posterior wall defects, basically weakening or tears in that back layer of the inguinal wall, they find those in about 85% of cases.
85%. Wow.
Yeah. And the most common spot seems to be the transversalis tendon, a key part of that wall. Less often, it might be issues with the internal inguinal ring or the conjoined tendon, other structures right in that same area.
So even though it's not a bulge coming through a hole, there is often real structural damage or weakening in that abdominal wall because of this stress.
Correct. And the sources directly link this damage to repetitive athletic movements.
Like what kind of movements?
Things like forceful twisting, really sudden changes in direction, sharp turns, powerful kicking. Those actions are thought to repeatedly stress these already potentially weakened areas, making the condition worse over time.
That makes total sense when you think about the sports where you see this a lot. What are the common ones mentioned?
Yeah, sports that involve those really high-impact dynamic movements. Soccer, American football, ice hockey, rugby, baseball, even track and field. They're all mentioned quite a bit. Basically, activities demanding a lot from the core and hips.
And your material also said that surgeons often find damage to multiple things in there, right? It's not just one isolated spot.
That's a really key point. It's rarely just one simple tear. When they go in, evaluation often shows injury affecting, say, the distal rectus abdominis. That's the lower part of your six-pack muscle.
Okay.
Or the conjoint tendon, which reinforces that inguinal wall, the external oblique aponeurosis, that broad tendon layer on your side, the inguinal ligament running along the groin, and often the adductor longus, that main inner thigh muscle.
So it really highlights how interconnected that whole area is and how the stress can spread.
Exactly. It shows the widespread impact of that underlying imbalance and stress.
Okay, so we have this picture now of structural stress, potential damage, all linked to muscle imbalance and repetitive motion. If you're an athlete going through this, what does it actually feel like? What are the typical symptoms the sources describe?
The most common thing patients report, according to your sources, is activity-related groin pain.
Okay, so it hurts when you're active.
Yeah, pain that flares up when you're training, competing, practicing.
Yeah.
But then it tends to subside when you rest.
Ah, that classic frustrating pattern. Does it just hit suddenly one day?
Usually not. The onset is typically insidious. It might start as just a minor ache, kind of subtle, and then it just progressively gets worse over time.
And where exactly is the pain?
It's usually localized to one side of the groin, but it's not uncommon for it to radiate. It might spread to the opposite side or even down into the scrotum for men.
And are there specific things that really set it off or make it worse?
Definitely. Any sudden movements engaging the core or hip forcefully can cause a sharp spike in pain. Also, anything that ramps up the pressure inside your abdomen.
Like what?
Like doing a sit-up, coughing hard, sneezing really forcefully, or doing what's called a Valsalva maneuver, basically bearing down, like when you lift something heavy or strain.
Right. Which brings us back to why diagnosing this is so tricky, like you said earlier. The sources really emphasize that even with these symptoms, there's no single slam dunk test.
Exactly. You'd think with all our imaging tech, right? But no, the sources are clear. It stays primarily a clinical diagnosis. It really comes down to the doctor's examination and knowing what signs to look for.
Because the symptoms overlap so much with other things that cause groin pain.
Precisely. So the physical exam is absolutely crucial. Your sources highlight 5 specific findings. If the clinician finds at least 3 of these present, it strongly points towards athletic pubalgia. This is really their main tool without a definitive test.
5 specific findings, like a diagnostic checklist. Okay, what are they?
First, pinpoint tenderness right over the pubic tubercle. That's a specific little bony bump at the front of your pelvis where several key structures attach, including that conjoint tendon we talked about.
Okay, tenderness on that specific bony spot. Got it. What's number 2?
Second, tenderness felt over the deep inguinal ring. That's an opening higher up in the abdominal wall, sort of the entrance to the inguinal canal.
And
Third is pain, or maybe some dilation felt at the external inguinal ring that's the lower opening near the groin. But here's the key part. This pain or dilation is there without the doctor actually feeling a distinct hernia bulge pushing through.
Ah, so it feels abnormal, but there's no tissue actually poking out.
Exactly. It ties right back to that misnomer thing, doesn't it? It feels like maybe a hernia is trying to happen, but it's not quite there.
Makes sense. What's fourth?
Fourth is pain right at the origin of the adductor longus tendon, where that main inner thigh muscle attaches to the pelvis.
Okay.
And fifth, a duller, more spread out pain across the groin area. This is the pain that might radiate, like we mentioned, towards the perineum, down the inner thigh, or even across the midline to the other side.
So those 5 specific points help the clinician build the case when imaging isn't crystal clear. Speaking of imaging, you said it's not definitive. What is its role then, according to the sources?
Its main job, really, is to rule out other possibilities, other things that could be causing that groin pain.
So less about confirming the sports hernia, more about making sure it's not something else.
Exactly. Like making sure it's not a stress fracture or a hip joint problem or even a true classic hernia.
What kind of imaging helps most with that?
MRI is generally seen as the most sensitive tool, especially for spotting those other potential issues. It might show things like tears in the lower abdominal muscles or the adductor attachments, maybe some changes in the pubic bone itself.
Okay.
But, and this is a really critical point from your sources, these findings, even if seen on MRI, are explicitly stated as not being specific enough on their own to clinch the diagnosis of athletic pubalgia.
Ah, that's a really important distinction. So you can see damage, but it doesn't automatically equal this condition. It could be from something else too.
Correct. That's why the sources recommend getting a pelvic MRI, often with IV contrast, and they really stress how important it is for the clinician to talk directly to the radiologist, explain their suspicion for athletic pubalgia to help guide how the scan is interpreted.
Makes sense. What about other types of scans? Any role for them?
Well, dynamic ultrasound is mentioned. That lets doctors see the tissues in real time while you move.
Oh,
Yeah, it can potentially show weakness or abnormal movement in that posterior inguinal wall, or maybe issues with tendons. But the sources note its sensitivity and specificity are a bit limited compared to MRI for ruling out other things.
okay. And standard x-rays or CT scans?
They're mostly useful for looking at the bones. X-rays or radiographs can help spot things like fractures or maybe femoroacetabular impingement, FAI, that hip joint issue. CT gives even more detail on bony structures and can show changes in the pubic symphysis, that joint at the front of the pelvis.
And one more mention was herniography. Sounds specific.
It is. That's where they inject dye to specifically look for a true hernia, that fascial defect.
Right.
The sources say it is sensitive for finding true hernias, but it's invasive, and it's not recommended as a first-line test for suspected athletic pubalgia, mainly because it's looking for that classic bulge, which, as we've said, usually isn't the main issue here.
Okay, so diagnosis really hinges on that careful physical exam, finding those specific points, with imaging mostly playing a supporting role to rule out mimics. Once someone is diagnosed, can it be prevented? Are there clear guidelines?
Yeah, this is another area where the forces are pretty upfront. They state clearly there are currently no universally accepted evidence-based guidelines specifically for preventing sports hernias.
Huh. That's a bit surprising given how common it sounds in certain sports. But I guess there are strategies that are thought to help, right? Potential ideas.
Oh, absolutely. While they aren't strictly proven prevention methods, the potential strategies that get discussed revolve around solid strength and conditioning programs.
Okay, what's the focus there?
The focus is generally on improving flexibility, definitely building core stability, and integrating movements that are specific to the athlete's particular sport.
And going back to that muscle imbalance theory, strengthening the core seems like the most logical starting point for prevention ideas.
It really is. The importance of identifying and correcting those muscle imbalances, especially between the muscles above and below the pubic symphysis, that pelvic joint, is a recurring theme. Strengthening the abdominal muscles is widely believed to be key.
To provide better support for that stressed inguinal wall area.
Exactly. By creating a more balanced, stable core.
And I assume these programs need to be personalized. A hockey player needs something different than a sprinter.
Totally. The sources emphasize tailoring any preventative strategies to the individual athlete, thinking about their specific sport, their current skill level, their overall physical condition, and any existing imbalances they might have.
Okay, so if prevention isn't a sure thing and someone does end up with athletic pubalgia, what's the typical treatment path look like based on your sources?
Well, the good news here is that non-operative management, meaning treatment without surgery, is the first-line approach for most people. And the sources indicate it's often pretty effective.
Okay, so what does that initial non-operative treatment involve?
It usually kicks off with a period of relative rest. Not necessarily complete shutdown, but significantly reducing the activities that cause pain. This typically lasts about 6 to 8 weeks.
And during that rest period?
You use supportive measures. Things like NSAIDs, non-steroidal anti-inflammatory drugs for pain and inflammation, maybe using ice or heat packs.
And then comes the rehab part.
Yes, after that initial rest phase, you move into a structured rehabilitation program. This phase usually takes about 6 weeks or so, and it's all about gradually getting the athlete back towards doing their sport-specific activities again, safely.
Are injections ever used as part of this conservative plan?
They can be, yeah. In some cases, targeted injections might be an option. They can be directed at specific painful spots, like where the rectus muscle inserts or the conjoint tendon or the adductor origin.
So you try this conservative route, first rest, rehab, maybe injections. When does surgery enter the picture?
Surgical intervention, which usually involves a procedure like a herniography, to basically reinforce that weakened posterior wall area. This generally kept for athletes who haven't gotten significantly better after giving the non-operative treatment a really good shot.
How long is a good shot?
Usually at least 2 to 3 months of dedicated conservative therapy.
Okay, so there's a clear progression. Try conservative first. Surgery is an option if that doesn't work after a decent amount of time. What does the rehab process itself actually look like, whether you ended up having surgery or just managed it non-operatively?
Right, so regardless of whether you had surgery or not, the rehab process tends to follow a pretty similar path. It typically moves through 3 distinct phases over maybe 2 to 3 months.
Okay, walk us through those phases. Phase 1.
Phase 1 is all about restoring flexibility and getting some basic control back. So that means working on things like hip adductor stretching, trying to loosen up those often tight inner thigh muscles, and starting core stabilization exercises. Just building that foundational core strength is really key early on.
Makes sense. And phase 2 builds on that foundation.
Yep. Phase 2 starts to ramp up the strengthening, focusing on the key muscles involved. It often involves eccentric strengthening.
What's eccentric strengthening again?
That's where you strengthen a muscle while it's lengthening, under control. So eccentric work for the abdominal obliques, the rectus abdominis, your six-pack, and those adductors. This phase is really critical for tackling those underlying muscle imbalances we talked about.
Right, correcting the tug of war, and then finally getting back to actually playing.
That's phase 3, the gradual return to sport-specific exercises. You start with more basic movements related to their sport and progressively increase the intensity, the speed, the complexity, until the athlete can hopefully participate fully without pain.
And deciding when someone is truly ready to go back.
That's always highly individual. Depends on which treatment they had, how severe the initial injury was, and, crucially, how they progress through each phase of rehab. There's no single timeline that fits everyone.
So overall, what's the outlook for an athlete who gets diagnosed with athletic pubalgia? What does the prognosis look like according to these sources?
Generally, the prognosis is quite favorable, which is definitely reassuring for athletes dealing with this.
And their chances of actually getting back to their sport, are they good?
Yes. Return to play rates are reported as being high. Overall, across different treatments, exceeding 90%.
Wow, over 90% get back. That's really encouraging. Is there any difference specifically for those who have surgery? Are their return rates similar?
Yeah, pretty similar for those who do undergo surgery. The sources cite return to prior level rates typically between 80% and 95%. So still very good odds.
Did any of the studies you shared give specific timelines for how long that return usually takes? Average times?
Yeah, a couple did. One study by Kajetanek and colleagues found an average return time of about 112 days after surgery.
Okay, roughly 4 months.
And another study by Castle and colleagues, looking specifically at NBA players, found an average return time of 4.73 months. So again, in that same ballpark.
That gives a pretty concrete idea of the recovery window. Did the sources suggest if surgery might actually get athletes back faster than just sticking with non-surgical rehab?
That's an interesting point. One finding mentioned by Seraphim and colleagues was that surgical management may potentially allow for a faster return to play compared to a purely conservative non-surgical approach.
That could definitely be a factor for an athlete deciding on treatment, couldn't it? Faster return versus avoiding surgery.
Absolutely. It's one potential consideration.
Are there any potential downsides or complications to be aware of? Things that can go wrong?
Yes. Unfortunately, it's not always a perfect outcome. The potential complications listed in the sources include persistent groin pain. Some people just don't find complete relief, sadly. And in some cases, failure to successfully return to their sport at their previous level, or even at all.
Okay. So let's try and pull this all together based on the sources you sent. Athletic pubalgia, often called a sports hernia. It's a very real, often frustrating cause of chronic groin pain in athletes.
Right. And it's tricky, partly because that hernia name is misleading. It's usually not a classic bulge.
The real issue seems to stem more from muscle imbalances and repetitive stress causing damage or weakening in that lower abdominal wall area and the tendons and muscles around it.
That sums it up nicely. And because the symptoms aren't super specific, diagnosis is challenging. It really relies heavily on the clinician's sharp eye during the physical exam to spot those specific findings, with imaging mostly used to rule out other problems that could mimic it.
Right. But the upside is, despite these hurdles, the outlook is generally pretty good. Most athletes can get back to their sport with the right management.
Yeah, starting with conservative methods like rest and targeted rehab, and then potentially surgery if needed, followed by that structured rehab focused on core strength and fixing those imbalances.
It really is striking how this condition highlights the body's interconnectedness, isn't it? How pain that feels localized in the groin can actually be a sign of a bigger biomechanical issue involving the whole core and hip region, not just, a simple tear.
Absolutely. It's not just about one spot.
Which leaves us with a pretty compelling question for you, the listener, to think about. Given that diagnosing this often comes down to a doctor finding the specific 5 points during an exam, and knowing what surgeons actually see when they operate, how does that reliance on subtle clinical signs rather than a clear scan shape the whole experience of dealing with chronic groin pain for both the athlete trying to get answers and the medical team trying to provide them?
And maybe also, Does understanding the real mechanics behind it, the muscle imbalance, the stress on the wall, change how you think about what it takes to build a truly resilient body for high-level sport? Something to ponder.